Every EMS leader carries a keychain. I'm not talking about the metal and the noise in the pocket, but access, responsibility, trust. Those keys will open doors to stations, systems, trucks, but they also unlock the culture, accountability, and the future of the people. Leadership isn't one key, it's a keychain.
Welcome back to another episode of the EMS Wizard podcast. I am thrilled to be back. We do have the leader of Venezuela, Mr. Maduro, joining us on this
Hold on,
episode.
hold on, hold
And
on.
what?
Actually, there's been a schedule change from that. Something popped up. I don't think he's
Oh,
available, so I had to get somebody else. But I knew giving you that name would bring you back to the podcast. So actually,
I
we
mean,
have
I'm glad to be back either way.
well, I actually got
We didn't know.
Dalton Barrett from Edgecombe County to come with us.
Oh, cool.
So anyway, sorry about that schedule change.
Hey, I'm good with it. That's my hero. Dalton's my hero for real.
Good to be here.
Well, I'll tell you what, Dalton. Why don't you tell the rest of the world who you are, for those that don't know you? And I know you've made a pretty good name for yourself across the state just from where we've been going, and meeting people. They know who Dalton Barrett is, but tell the ones that don't who you are.
Sure. My name's Dalton Barrett. I serve as opioid settlement coordinator, logistics officer, community paramedic, whatever you want to call it, out here in the East in Edgecombe County.
Whatever you want to call it. You just got the bucket dumped into you. And you do logistics there too, huh?
Yep. Yep. Logistics and medical equipment, ordering of all of the things, and then kind of the CP world as well. So I get a little bit of everything.
I really love logistics. It's like my favorite. If I could just do one thing to ensure that I had to secure a 25-year pin, it would be doing logistics at Edgecombe County. That would be my dream job.
It'd
I
only be
think,
1 year.
yeah, I think it would be 1 year, number one. And I think question number two, well, number one for question number two, I believe that Facebook declares you as Dalton Nevada Barrett, and I think that's a strong middle name. It should be included every time that we say that. And number two, I thought Mr. Brown, I thought the director, he loved you, and yet he is inflicting many things upon you. I've got questions.
Yeah, Nevada. Yep, that's my real legal name. Never been there. Hope to one day visit. So definitely, that one's on the bucket list for sure. I'd love to somehow get a sign back from there and hang it up on the wall in the shed, but we'll see about that. But yeah, Antoine's around. We have got a lot going on. I do a lot of things, but it's all for the good of the company and the good of me. I enjoy what I do, and I've learned a lot along the way, specifically the last 4.5 years.
Tell us a little bit about your journey. Where did you start at? Where did you come from? Let's get to that, and we'll probably have questions.
Sure. Born and raised in Eastern North Carolina, was born in Clinton, in Sampson County. And 2 years later, I moved to Rocky Mount, on the Nash County side. My dad's a pig farmer, so all of my family's from upstate South Carolina. He went to Clemson. I'm a big Clemson fan, and that's what drew him to Eastern North Carolina. So I grew up kind of doing the pig farm life. Knew that it was fun, it was enjoyable, but there was something else that I needed, which was healthcare of some sort. In high school, I did the Health Science Academy and rode around with a paramedic, in Nash County a couple of times and really fell in love with the career. So kind of knew that that was what I wanted to do. My parents were very wanted pushed me to doing a degree of some sort, and the only bachelor's program around that was close by was Western Carolina's program. So I went there in person, graduated from there with my bachelor's degree in emergency medical care, and then went back to work, for Nash County. I was working part time at Nash County around 2013, just as an EMT. And then once I graduated with my paramedic, I went to work full time there. And then after that, I promoted up to what they call station officer, which is kind of like senior paramedic. And then it's a step below FTO. And then in 2021, I met John. I was teaching at the college at the time. He was working for Edgecombe County EMS, which was a new county system. There was a private rescue squad here before, but the county took over, and there was an opening for shift captain. So promoted from working the Kelly shift, just kind of on the truck at Nash County, which I knew, years to come, I'd be in line for a promotion, I was sure. But, was still a few years away from that. So made the choice to come over for a little less hours per year. So I was working 24/72 when I came aboard as shift supervisor. And initially I was over compliance. So that was fun for a bit. I learned a lot with that. And then 2023, my daughter was born in 2023, 22. So I was still working those one out of every 4 days, which was really hard on the family. And an opportunity come up in 23 in May to start the post overdose response team for Edgecombe County. It was kind of a partnership between the health department and EMS at the time. So I took that job. It was kind of a normal Monday to Friday, which I was used to working shift work. So I had to get used to that. But since then, things have evolved. I've taken on more responsibility, but I still, get my hands dirty with the post overdose response team, as well as, I still go out on EMS calls as well. But yeah, so since 2013, I've kind of been more of an administrative role with a normal banker schedule type of deal. And it's been really good to me. So that's kind of how I landed in the position, and just a real quick, overview of my EMS experience. I am a board certified community paramedic, and that was one of the hardest tests I've ever taken. So if anybody's looking to do that, just know to study up for sure. And the bachelor's program at Western, I didn't take a test that was harder than the CP test. So that was way worse than anything I took when I was a catamount.
So Dalton, I know we're going to talk a bunch about the CP stuff, but I just want to interrupt real quick because you talking about your experience at Western Carolina, and maybe that's the direction John wanted to go in. But talk to us a little bit, because you weren't you the chief of EMS out there, and that's EMS in a little bit different lens, a little bit different view. That why don't you share a little bit about your experiences out there with University EMS and that student leader role?
Sure. When I was in college, there was a lot of loans I had to take out. Obviously coming from an agriculture family, we didn't have a whole lot of means to just go out and pay for college. So I knew I had to work. I worked with special needs kids while I was there. I was a tour guide for many years. But the one thing I was really excited about was the on-campus based EMS system that's run by students. It was the first one in the nation, been around since the 70s. And, I started part-time with them just after I got my EMT my freshman year, which was 2012. And then, they have a kind of an officer structure there. And one of the benefits to that structure is that if you're an officer, you get free housing. And I knew that that would save me some money. So I became captain first. That was my junior year. And I did logistics there, which didn't know that I'd be doing it down the road. So that was cool. And then my senior year, I was chief of EMS there. We had about 20 different employees. We staffed one ambulance and one QRV, kind of during the normal, school year. And then when we had football games and basketball games, we would kind of, had different standby crews. So it was just a great opportunity to get some experience, not only with patient care, but also with some leadership and some personnel management really, really early on in my career. So I think that kind of definitely prepared me for what I would be doing in the years to come. And I just didn't know it at the time. So it was a great opportunity.
So
I
one of
think
the things
that's
you mentioned a while ago, Dalton, was the port team, the post overdose response team. Um, Not everybody has those, and I think that's something that's still kind of becoming more and more of a thing in EMS in North Carolina. Tell us a little bit about what that is and what that work actually involves.
So, really, the reason for starting the opioid response team in this county was kind of some fallout between the opioid settlement, all the litigation, all the funds that are starting to hit the counties back in 2022. The health department knew that we needed someone in the community to go out and educate and keep people alive and get them into treatment, just because overdose mortality in our county was really, really high. and treatment options were really, really low. So they wanted someone to just go out into the community, along with, some of the other strategies that you can do. And it initially started out as kind of a one-man band. What we would do is we just get some referrals from EMS, whether it be somebody who has had an opioid overdose, or they're calling for withdrawal symptoms or something like that. So we kind of came in, kind of viewed what the traditional response to, an opioid overdose was, which we weren't really satisfied with that because it was essentially respond, Narcan, withdrawal, refusal of care, relapse, respond, Narcan, withdrawal. And it was this vicious cycle. So we knew we had to implement some things to change that a little bit. I'm happy to talk about some of the services that we do with the port team, but definitely one of the models for the state right now, very well recognized in the state for doing opioid response with board certified community paramedics. We don't have a peer support. So that is something that's a little different about our system than, traditional post overdose response team models.
The question I got is, what do you think's the single? I have two questions, but one is, what do you think is the single biggest impact that you did in the port, like that made the difference? You just described that little relapse part that goes through, but what's the thing that you did that you said that was the missing piece? That's the thing that we did that turned the tide.
Yeah. And it's really, with it being a one man band, we had to make sure that our providers at nighttime or on the weekends were treating people with compassion. So honestly, I think my one thing that changed the game, despite all of the cool things that we do, is having compassion for people, and knowing that things can change and we can do other things. But, treating people right while you're in person with them really builds trust. And there's been years upon years of mistrust in that community. So when someone comes along, that is honest with them, that's compassionate, this is something new. So they open up, and they're definitely, will be honest with you about their history. We'll be honest with you about some of the challenges that they have, and other things that are really affecting their opioid use, which is a very complicated thing to fix. Obviously, a septic patient in the back of an ambulance that has low blood pressure and high heart, obviously that's complicated too. But really, opioid addiction is much more complicated than treating, a bad medical or a bad trauma patient.
And you said mistrust. So, were you talking about mistrust from the patient looking at
Yeah, just
EMS?
in systems, whether it be healthcare, whether it be EMS, law enforcement, whatever, their survival instinct has been refined over time to lie and to evade and those types of things. And when you build trust with that person, those walls are torn down. You can really work on the root of their issue. So. Um, in a nutshell, I think EMS kind of around the country has done a bad job at, doing response to these things. Obviously, there's reasons for that with provider burnout, um, and things like that. But for the most part, if you can change, some of the humanity between those encounters with people, you can get a lot more return on your investment. And that's with a post overdose response team or not. I mean, you can do the same things that we do on the back of the truck a lot of times.
Do do you think that's the secret sauce? Because I heard a story one time about somebody who rode along with you that somebody from Leadership Academy was spending some time with y'all out there in Edgecombe County, and they were really impressed with they had talked about showing up to this hotel with you, and they were like, this is the type of hotel like you wouldn't normally stop at. And they said everybody is out, on the stairwell and the porches, hey, Mr. Dalton, and had talked about one of your customers, one of the clients, one of the folks you were there to see and to visit, had bought you a keychain. And these are folks that they have limited means. They're falling through the cracks. There you are to be that safety net. So do you think that's some of that safe special sauce? I tell that story because I think you're not giving yourself enough credit that there's some amazing stuff that y'all are doing in Edgecombe County. and some folks might not understand that.
Right. Yeah. I think was it the Walt Whitman quote that says, "Be curious, not judgmental." Like that's really the thing that we've kind of carried along with us from the beginning and also until now as well. And just trying to get other people on board and get people bought in to that compassion, and that, treat people with dignity no matter who they are. Like EMS people say that all the time, but like let's peel the scab back. Like what's really happening? Are you going to the nice neighborhood and treating those people different than you would the homeless person under the bridge or the drugged out motel? Like those should be the same. You should give the same amount of heart to those patients as well. And those people in addiction, they can see right through that in about 2 or 3 seconds. Like they can look at you and tell. So they're very good, character judges, I would say. So having the right person makes all the difference.
So, Dalton, what drove you? What made you want to do that? Like you talked about, I mean, to go from like the university model that you were in to being in Nash and going through that, that's pretty traditional of some folks that go through that and do that. But what to have a passion like it seems like you have to not only, hey, I mean, I want to do a job, I want to do the work that goes into it, but what was the inspiration, maybe is the better question. What was the inspiration for you to jump into that?
I think it was really the first time that I was kind of allowed to here are the reins, go and be creative and do this thing well. And that's what I went to school for. Yeah, sure, I'd be a assistant supervisor, supervisor one day, and I was those things. But this was really the first time where I could break the mold myself and be creative and come up with things that maybe didn't make sense to people and try things out. So I think that was really what started it off. And then as I kind of fell into it, I really have a passion for people that are struggling with drug use because that is, it's everybody's family member. It's somebody's friend. It's somebody's dad or mom. Or, we ask the question a lot of times, have you ever been impacted with substance use? Or do you know somebody who's dealing with an addiction? Put your hand up. And if your hand doesn't go up, you're still impacted by that person. You just don't know about the addiction yet, most likely. So I think I come to terms with that. I can think back to a lot of people that I grew up in high school with that, I ended up giving them Narcan in Nash County. I wish I could do more for them. So, fast forward down the road a little bit, I wanted to, create something that would it would provide more instead of just that vicious cycle that I talked about that is so frustrating to EMS providers as fixers, right? Um, but that was another thing that I had to learn is I can't fix this. But if I can serve someone, that mindset kind of shifts a little bit, right? Because if we think I'm going to fix their situation or I'm going to help them, like that kind of elevates where I'm at. Um, and that's kind of the wrong mindset. It's more of like a service mindset, in my opinion. So,
More of a thing that you're not going to fix the problem. You're just going to continue to treat and manage the problem kind of thing. It's a
right.
continual process. It's not a one and done kind of thing.
Right. Yeah. Obviously, this versus somebody's blood pressure is much different, but the service mindset gives me a little bit more prevention of burnout as well. Because if I'm thinking I can just go out and fix all the problems, I can go help people and do all this, like I'm going to get burnt out very quickly. Whereas if I just picture myself as serving this population or viewing what I do as a service mindset, I think that changes a lot. Kind of keeps me motivated even when things don't go wrong or when things go wrong.
So whenever John decided he wanted to interrupt me, I think he missed me that much, and he hasn't interrupted me, and I don't know how long, how many episodes now. So he's had the opportunity now. Um, but one of the things you talked about earlier was that developing trust with your patients, and not only just developing trust, but having to recreate from that mistrust that was developed at some point in time to move forward. So how for those that are probably either new to the profession as a provider, or even those that are in management or leadership positions that have the same responsibility of developing trust, not necessarily just with their patients, but with maybe their colleagues or their supervisory team, their admin team? What's some of those tactics that you've used with patients and colleagues over time to kind of help develop trust?
I mean, the patients, obviously, there was a lot I needed to learn about drug use in general because, I grew up, I was, opioid free until I broke my jaw. I was on opioids for a period of time, but was never addicted to opioids. So there was a lot I had to learn about the drug market, the drug market and distribution and those types of things now because the landscape has changed a lot over the last 15, 20 years for sure. Um, but as far as our providers, the healthcare system, community leaders, and things like that, we really had to start there because we went to the calls, we saw some of the encounters with EMS. They weren't good. They'd wake somebody up with high dose naloxone and they'd be in withdrawal, and there's law enforcement and EMS like screaming at the patient, and that was just a terrible situation. So we had to fix that, but then we also had to educate the hospital on, now there's somebody who can do something a little bit different. So utilize this person. And anytime we did Narcan trainings with the community, whether it be the school system, the local power company, the town of Tarboro, Rocky Mountain Events, all of the different ones that we've done, we always put a little bit in there about opioid use disorder, and why people act the way that they act, and some of the ways that you can support someone without enabling them, and all of the things to try to bring a little bit more awareness to this thing as more of a disease than just a character flaw. So that was at the heart of it. We had a lot of education to do. We're not perfect. I'm sure we still have issues from time to time, but that is something you have to work very, very hard on to start off with. You don't want to, have your program ruined because you had a bad encounter with somebody. So, and that credibility spreads quick. So, as Terry said, the folks at the motel, I may have met one on an overdose, but then they've gone back and told that motel of people that this guy was really nice to me and he gave me this and he did this for me and he went to bat for me and, had a good encounter with them. Like it could have been just that one time, but those impressions last a long time and they spread quick. Um, there's a lot of stories I can think about how I've treated one person and then that person I treated went and treated their friends. So that was really, really cool. But Terry was talking about the keychain. That's it right there. It says my name. And that patient, she could barely afford her room at the motel, but saw the keychain at a gas station and picked it up for me. And that was a really special moment for sure. So I'm glad that writer got to write about that. That was really cool. I'm glad you brought that up.
So before, because we'll switch directions in a minute. If you were giving advice to, because a lot of this sounds like to me having the right person in the right position that has the right disposition, but if there's a chief who's listening who's saying, hey, I'm trying to get my hands around this, or maybe somebody who they want to get into that management of just that CP side, because you've got your fingers in a million different things, and so for just that CP side, what would be a piece of advice that you would give to somebody?
Like if you're a chief and you're looking to staff somebody to fill those roles,
Yeah.
obviously I think somebody who's self-motivated is number one. That's just about the job. You're one person, you're going out by yourself, you have to find patients, you have to do this. So obviously self-motivation is key. And then some of those soft skills, like I mentioned, a compassionate person, they've got to be squared away clinically. They've got to communicate well with other professions. So I've not worked an EMS job before to where I've dealt with this many different stakeholders between, the people we serve, but then also the hospital, primary care providers. It's this whole network of things. DSS, because many times does someone have issues with children or issues with where they're living at or even law or justice involved individuals as well. So like I've never worked an EMS job where I've had to deal with law enforcement, with DSS, with all of these other outside agencies. So obviously a good communicator would that to me that's one of the high priorities as well. And then someone that, like you said, they may not know a lot about the job, but if they can have some passion for it, if they're creative, I think that goes a long way too, because every system is going to be different. Um, And I didn't know a whole lot about, the opioid supply until years down the road where, you know, I got my education from the streets. So those people that live in the motels, I would just go for an afternoon and talk with them for hours and just ask them, how'd you get here? And tell me, how do you use drugs? Like, what's the process? I don't even know. So I learned a lot from that too. And that builds trust with those people. And then they talk, right? So it's pretty cool. I can go to someone's house that uses drugs in Tarboro, and, you know, it's like the same group of 200 people in Edgecombe that, like, they all know each other, this inner circle. But it was very hard to, like, get into that circle, if that makes sense. You may meet some people on the outside, but you never really get into that circle until there's some longevity there as well. So it takes a little while to get there too.
I mean, you said it with you having to build trust. There's a lot of those dynamics there, and I'm not aware. I've never had to be a part of a port program or anything in any of the agencies that I've been affiliated with. That's sort of something that's been in the last few years. So a lot of this stuff is novice level for anybody getting in, I would think. And me personally, knowing your story as you go through there, it was a lot of on the job training that you had to do. But it sounds like the principles you used were ones of, like you said, creativity. You'd have to come in with trying to seek solutions at potential roadblocks that you had. It wasn't oh, you can't do that, more than it was, how do I skirt this? How do I remove this roadblock so that, because you said a lot of agencies, that that's not in the book, right? How to work with DSS and then law enforcement and then hospitals, and everybody sometimes have a different agenda at the table. So I can imagine that kept you up at night trying to figure out, you know, how am I going to please all these different people at the table to get a common goal? Was it that way? Was it a struggle to have to work through those groups?
Yeah, and like you said, whatever, as we learned about, like, the treatment environment and what roadblocks these individuals have, it was always like, well, how can we get around that? How can we push through that? And there were some roadblocks for sure. But one thing that I would say to anyone who, falls into a similar role that's kind of starting out is, don't take no for an answer. You can always figure out a way to get around a hurdle or a barrier. And all of the services that we've added has always been about, like, decreasing barriers and in a creative way. So, like, one of the things I think about is hepatitis C testing. So it was that, IV drug use, you're high risk for hepatitis C and some other things. We go to somebody's house. We'd love to get you tested. Well, can't you just test me? Like, no, you have to go to the health department. So we talked to the health department. We were able to do hepatitis C, HIV, and syphilis testing at someone's house. Well, we would get a result in 2 weeks, and trying to find that person again was like, daggone, this is like put my ear to the ground and try to figure out where they went, because, phone numbers change, locations change. It was almost impossible. So I was like, well, what can we do to shorten that up? So now we actually have a machine that does point of care hepatitis C testing, and then we get a result in about 45 minutes. So that was one of the services we did that we hit some roadblocks, but in the end, we have a deliverable for our patient. And it's been a very effective tool. Same thing with Suboxone inductions and maintenance with that. Same thing with a lot of these patients. You can't get blood work on them traditionally, so they'd have to go to the hospital and get an ultrasound done. Well, we have an ultrasound, and a lot of those things were like heavily financial burdens, but there's ways around that. Basically, every high tech piece of equipment that we have is grant funded somehow, and that it fortunately it worked out for that. But there's a reason for each piece of equipment that we have. Just like we were confused. We'd see someone who uses cocaine, they would have a opioid overdose that was textbook, and we're trying to figure out why that is. Or we'd have someone with an opioid overdose that had dilated pupils and tachycardia, and we're trying to understand that. So we actually test street drugs and send them off to UNC to run through mass spec, and we find out what's in the street drugs in about a week or two. So all of those different things that we have done was because of an inquiry that we had or a barrier that we noticed with a patient, and we didn't want to run into those same barriers with future patients. So we try to change something about what we're doing.
And you said you started out, you were basically a program of one. And basically that program of one only could survive with the passion and drive that someone would have to do it. So if people are out there in an agency, I mean, I'm making some assumptions here. How you're funded through your normal budget, right? You don't have hospitals not paying you money. There's not some other thing, or is there some other pot of money that comes to you that was waiting for you to use, or did you have to justify your existence to receive, funding for that? And if that's the case, how does someone can you lay out a roadmap for the steps for that?
So we're about 85% funded through the opioid settlement funds. So not technically a part of the normal calendar year budget for EMS. So we're funded kind of through a special revenue fund called the opioid settlement, in which every county in North Carolina gets. And that's just an authorized strategy. So happy to walk through that for anybody out there who may be listening that's confused about how that happens. But with that being said, you still have to justify yourself, right? You still have to show a return on investment. And one of the ways to do that in a small place is using qualitative research, specifically with substance use, because the numbers are kind of rough. So you might go to 100 overdoses, and a year from now, how many of those people are in care or consistently in care? It's pretty low numbers. So you have to use stories, patients' experiences, and qualitative types of metrics to really showcase how important that job is. And we partnered with Duke University, the School of Nursing, over the summer, and we interviewed 7 different participants that came through our program and got into treatment, and they were doing well. And we used those participants to do a qualitative research project called a photo voice exhibit, which is essentially where we give them different prompts each week in group sessions. And the prompt may be, what challenges did you have in recovery, or something like that? And they would have to go and take a picture of something and put a caption with that picture, and that would be the answer to their prompt. And after that, it was like 6 different weeks that we did that. We got all of the data and the pictures and the captions, and we did a public art exhibit with those pictures at the local community college, and we invited anybody that wanted to come. We had dinner there, but it was essentially not only their stories of recovery, but qualitatively how the community paramedic program or post overdose response team assisted them into whatever prompt that we had for them. And it was a CLIA, it was, or not CLIA, it was a IRB approved project. So it was an actual clinical research project. And we had a lot of training to do. There was a lot of hurdles with that, but that really paid off. And that was a beautiful exhibit that we did. So that's just
That
one of the
sounds
ways that you can justify what you're doing. And really, everybody's got their mindset on, needle programs or medication assisted treatment, but like being able to attend an event and hear about how those programs or how those services change someone, those can kind of help to break the stigma that people have as well.
sounds awesome. Sounds like a lot of work went in to kind of be able to justify that qualitative research project and everything. Sounds great. I know there's probably some agencies, and myself included, that would go back and look at, well, I'm wondering what could I look at from an agency perspective to see where maybe we have this need for a port team or what we could do. So we I sat down with my emergency services director a couple of weeks ago. We were looking through some just random reports, I say, from ESO, and looking at uh, instance of Narcan administration, instance of primary impression being overdose, so on and so forth, and all those numbers come back like surprisingly low
Mhm.
to us. So we thought, well, maybe they're just not contacting EMS. Like, how often is this maybe more of a law enforcement thing, or how often is this actually happening? And there's no actual recorded data on it. So yeah, did you guys have any trouble with that? Kind of starting out early on to kind of show that, yeah, this is some funding and to show the need for it.
Yeah, I mean, obviously, our overdose mortality was really, really high. That's overdose deaths per citizen in your county. We were one of the highest in the state. So that was one of the things that we had working for us, for the program, bad for the community, but good for the program to justify existence. We looked at some overdose figures, but what I understood after entering those closed off circles of people using drugs is that there are significantly more overdose reversals happening, that just don't get reported to EMS, that don't show up at the hospital. So you may not see those numbers objectively on the state's website or on ESO or something like that, but drug use is happening in the community. And those numbers you can't put a figure on that. So you really have to dig in, and it could be that you could use stories from encounters like that to showcase what the substance use, you know, environment looks like in your county. But there's some good numbers. Obviously, overdose deaths, those are good to look at. But really, foster care due to parental substance use, that's a really, really good number to look at too. That's one that kind of flies under the radar. Greene County is one of the lowest overdose death rates in the state, but they have one of the highest foster care for parental substance use rates in the state. So that kind of shows that drug abuse is still happening in those areas. It's just maybe not killing people, but it definitely is causing trauma with children, which is one of the things we're trying to prevent, right? Is this adverse childhood events, right? Because that puts you more at risk for substance use down the road. So this thing is like what we're doing right now will hopefully, we may not see the effect, right now or in 5 years. We are seeing some good trends, but we're really trying to protect what's going to take place in the next 10 to 15 years.
So Dalton, I want to keep chasing the rabbit, but I think I'm going to take a 90-degree turn here, and the question that I have, and kind of throw you on the spot, and nothing top secret, nothing whatever, but Rocky Mount recently hosted a presidential visit, and I know that it was a cold evening when the president visited y'all, and that location of that visit, literally right on the railroad tracks. Actually, one of the places I stop in Rocky Mount to watch trains is there at the event center, and so from taking 1, 2, 3 minutes, whatever, for those who maybe might have to experience one, or just through that lens for a minute. What did that look like as a county EMS provider, having to coordinate with some partners that you might not ordinarily, or what did that look like? I know that you'll have a great mutual aid relationship with your neighbors on all the sides, but what did that look like?
Yeah. Luckily that wasn't our first rodeo, because about a year ago or a year and a half ago, they had a rally.
Yeah,
Granted,
yeah.
he was not the sitting president at that time. So I was fortunate enough to work both events and get, both sides of that. There was significantly more people at the first one. Security was really low on that. So fun event, a lot of people, pretty, basic planning went into that. But this time around, complete game changer. So when Secret Service is involved, that changes the game for everything. So basically, we at the event we had kind of a medical branch set up under operations as far as the ICS stuff goes. I served as the medical branch director, had some floor crews, had some ambulances in the motorcade. Had to work with some incoming crews. If we had patients to get out, we had a treatment center in operation. So really, those presidential visits, especially in a small county, could be a great opportunity to activate your incident command structure that probably only gets activated out here for hurricanes and snow events, right? So it was a great dry run for that. We were fortunate to not really have much going on, so that was really cool. But yeah, working with the Secret Service, one of the ways that we see things differently is that since we are such a small system, I had 3 crews that were on site. And we had some ambulances there. But our thought process is, since we had such a high amount of attendees, that if we had a medical call come out, we were going to contact one of our 911 ambulances to come to the scene to retrieve that patient and take them on. That way we maintained a really, really high level of EMS staff there, or as high as we can, right? Especially if it's not something that's time sensitive. Obviously, if it was a stroke or a gunshot, like we want to get that patient out. But we had a guy that had, low heart rate, low blood pressure, but contacted the outside EMS truck. They came in. Of course, they had to get sweeped, right, by Secret Service. And, kind of stepped on the guy's toes initially because he's like, we got ambulances here, but we weren't, 45 minutes into the event. So, I had to kind of explain to him about, we're trying to triage this person. We don't want to send all of our medical staff out of here and then something worse happened. So that was, it was pretty interesting working with them and trying to see things from a different lens. But it was a great experience for me. It's good, just because we don't activate ICS very often here, fortunately. So good dry run of that as well.
My final question has to do with what you said in the beginning, and you mentioned you glossed over this, almost got by us. You worked as a tour guide of what?
I was a tour guide for the university. Yep.
So,
So any open house that took place throughout the week, high school kids would come. I had a group of students that pulled up in a wheelchair. Like there were like 15 wheelchairs, and I was like, "This is like a walking tour. Like, what am I gonna do?" So I remember that was a heck of an experience. But yeah, so that was just one of the jobs I had. It was like $12 an hour. Went and gave weekly tours to people thinking about coming to the college.
you crushed my dreams. I was thinking ghost tour with
Stupid.
Dalton Barrett.
Stupid.
Well,
It
we
would have
did
been
have the
awesome.
body farm. We had the body farm at Western, so we talked about that. And we pointed that location out to people. So I guess that counts. Maybe not ghosts, but decomposing bodies could be the same thing, right?
Close enough.
I'm
So
going to tell the story different. You were a tour guide. You did ghost tours at Western Carolina. Got it.
I was a raft guide on the Nantahala. That'd be
John,
cooler, in my opinion.
John is not afraid to stray from the truth. So before Mark does the final question, because I think we're probably over on our time. Dalton, you're doing a lot of things. We didn't even touch on logistics. We didn't even touch on whatever. We really went down that community paramedic rabbit hole, and it's always curious to see the differences with things. But Dalton, I think a really good community paramedic probably needs a really good best friend to support them in those endeavors. And so, if I were to say, Dalton Nevada Barrett, who is your best friend? What would you say?
Mm, I've got a village of people that I have that support me. At home, it's my wife and daughter. Those non-EMS people that I can talk to and hang out with and get some stress off. But obviously, Director Brown, Antoine, he's my best friend here. Obviously, he's my best friend. We talk every day. We hang out. We tear stuff up together. We get frustrated together. So, really having a mix of people at home, people in your company, and then I talk to a lot of people around the state. I have a lot of respect for Josh Holloman at Johnston and Dustin Swinson down there in Duplin and some other folks that I talk to regularly, Skinner at Green. And it's just good to talk to those guys and Brad Cooper over there at Randolph. So, I mean, I could go on. But really, it's like a family reunion when we come to the admin conferences. And I think that really helps me stay the course and stay motivated.
So if I had to guess, if you continue to work down that list, you would probably get somewhere down to about 100 or 200, and maybe John's in that list somewhere around that area.
There's a bunch. There's a bunch. Obviously, John's the reason why I'm here at Edgecombe, so I talked about that story to start off with, but had it not been for him, just being, hey, it's time to do this. Nobody's ready for this. I mean, I wouldn't be here today for sure.
No,
Not
that's just
blowing
going to
his head
go
up or
to his.
anything, but
It's going to go to his head. We don't. That's
Yeah.
probably where we.
Yeah, solid 200.
so with him being a quitter like normally, he opened his
Oh,
mouth
okay,
and
yeah.
so it worked out. It worked out.
Join us for another episode on the EMS Wizard podcast, where we learn about John being a quitter and a